You are not audible.
Can you hear me?
Yes, now.
Yes, sir. Thank you. So at the very beginning, I would like to thank the organizers for giving me the invitation. And without wasting much time, let us begin our discussion. Next, one second, sir. Yes. So today we shall be discussing beyond glucose control, elevating diabetes care from a glucocentric approach to metabolic approach with dapagliflozin and its combinations. We start with a case vignette, 53-year-old man who is a diabetes for more than a decade, hypertensive, smoker, as well as having obesity. A1C is 8, EGFR 55 amounting to CKD stage 3, having dyslipidemia and BMI more than 29 and USG abdomen showing fatty liver grade 2. His present medications includes metformin, sitagliptin, rosuvastatin, and telmisartan. So if you look into this patient, only as far as glucose is concerned, hyperglycemia is rather to be considered as a narrow view of a vast field. And glucose excess is only one of the phenotypic expression of a plethora of linked metabolic perturbations. So now we should switch from glycemic-based care to metabolic care that will address the liver, heart, kidney, as well as the body weight. So when a person, healthy people, becomes less exercise prone, there is low energy expenditure, have bad food habits kind of things, he accumulates fat. And the fat cells, so the adipocytes, are active endocrinally. And they secrete a number of important mediators like pro-inflammatory cytokines, leptin, adiponectin, TNF-alpha, free fatty acid, ROS, etc. So together, it culminates into insulin resistance, lipotoxicity, dyslipidemia, fibrogenesis, and whatnot. And that brings about obesity and other associated diseases. So if you first look at the fatty liver or NFLD, type 2 and NASH, they goes hand in hand. They are basically partners in crime. If you have type 2 diabetes, it increases the risk of NASH. And if someone has just fatty liver disease, non-alcoholic, it increases the risk of diabetes as well. We can really rename the non-alcoholic fatty liver disease as metabolic dysfunction associated steatotic liver disease or MASL. And when this steatosis gives way to inflammation or hepatocyte injury, this can be MASH in spite of NASH, that is metabolic dysfunction associated steatohepatitis. So these things need address apart from glycemic control. Now, what are the drugs we have to address these issues? The age-old pioglitazone is definitely our first preference or a number one choice, keeping in mind that it helps to control your insulin resistance at different level, as well as a good effect or positive effect on fatty liver disease. But my next speaker, Dr. Deka, will be talking on this pioglitazone in greater detail. So we are skipping it. So what about the other molecules, namely SGLT2 inhibitors that are the current talk of the day, and they can help us in managing the diabetes patients in a number of ways. How? The SGLT2 inhibitors, first of all, reduces hyperglycemia. There is reduction of glucotoxicity and improvement of insulin resistance. There is loss of calories, loss of body weight, and it also reduces the hepatic de novo lipogenesis, hepatic inflammation, apoptosis, the endoplasmic reticulum stress, and oxidative stress. So together, it increases the hepatic metaoxidation and reduces the amount of inflammation or steatosis in the liver. So it can be very healthy, it can be very handy in our armamentarium to start this molecule, particularly the persons who are having the NFLD thing or body weight is increased. So for our case vignette, we can really think about this kind of molecule. Now, what about the cardiovascular disease? This is much talked about. Every person present here knows a lot about this diabetes and cardiac agglomeration. Globally, about one-third of patients with type 2 diabetes have cardiovascular disease, and they have an increased risk of other complications like myocardial infarction, stroke, heart failure. We know all of these things. So CV disease occurs early and the leading cause of death. So what are the drugs we have really that actually prevents or improves the cardiovascular mortality? The SGLT2 inhibitors, the GLP-1 receptor agonists, obviously tops the list. So what about the SGLT2 inhibitors? I'm just stating a data regarding the importance of early use of SGLT2 inhibitors. Using data from AMD annals, about 2.5 lakh population that has been included in the study. And what they are using, they are studying the Dapagliflozin molecule of the SGLT2 at a very early stage. It is starting from the 0 to 1 year. And they have actually tried to show that the sooner you introduce the SGLT2 inhibitors, the better is the outcome. This is one plot that is showing the hazard ratio is increasing with your duration of diabetes and with increment of the A1C. Very simple to understand. Significant trend towards increasing risk of CVD with increasing level of A1C, fine. But what happens when we introduce dapagliflozin early? The black colored boxes represent the cohort using dapagliflozin. And here we can see that initial part, 1 year or 2 year exposure, the hazard ratio is reduced, and that too statistically significant way. So early introduction of SGLT2 inhibitors in 0 to 1 years or 0 to 2 years reduces the association of glycemic control, better association of glycemic control and control of cardiovascular diseases. This is typing. Whatever we talk about the management of cardiovascular diseases in patients with type 2 diabetes, whether they are having only atherosclerotic cardiovascular risk factors, whether there is established atherosclerotic cardiovascular disease with some amount of heart failure, be it with preserved ejection fraction, moderately reduced ejection fraction, or reduced ejection fraction. Whatever it is, we have been enlightened by a number of studies that as a class, SGLT2 inhibitors, they are beneficial in maintaining these things to a large extent. Highly prevalent undiagnosed complication, this is heart failure. Between 25 to 40% of patients have these, and about 70% of patients, they show even sign of asymptomatic LV dysfunction. Even in the ESC guideline also, there is recommendation that SGLT2 inhibitors are very much recommended in patients with type 2 diabetes with multiple risk factors or established atherosclerotic heart disease, and they all show to have a class 1 level of evidence. We can consider different liflozins, IMPA and DIPA. They have robust backup studies behind them, and the other molecules are yet in the pipeline. This is a focused update of ESC, and they also recommend as a class 1 level that SGLT2 inhibitors, they very much useful in the patients with heart failure with mildly reduced ejection fraction as well as preserved ejection fraction. So these are the options we have for heart failure patients. And here, apart from these usual cardiovascular drugs like diuretics, ACE inhibitor, ARB or ARNI, so DAPA and IMPA, these are definitely belongs to class 1 management product, class 1 drugs in our armamentarium. Okay, so this is how actually SGLT2 comes to be beneficial in heart failure. It actually shifts the metabolism in the heart from a glucose-centric to fatty acid-centric energy expenditure. And it enhances the expression of between one HIF, that is hypoxia-inducible factors, as well as AMPK, and reduction of the mTOR expression. So together, the restoration of autophagy and removal of cardiac remodeling, that is a pathological explanation for this benefit. Okay, this is just a gruesome picture showing the prevalence of diabetes, that is 2021, more than 537 worldwide. And the incidence of chronic kidney disease is also increasing as a pandemic of diabetes is really killing us. So what happens in the diabetic patients with CKD. Our case had an EGFR of 55, so he has already entered CKD stage 3. So he should have the usual things like incorporating healthy lifestyle, physical activity, cessation of smoking, as well as weight management. And the KDIGO guideline states the first line drug in your type 2 diabetes management patients, though it is metformin, but we should also try to initiate an SGLT2 inhibitor, particularly when the patients are obese and there is no obvious or overt contraindication. And it can always think about GLP-1 receptor agonist if needed to achieve the individualized glycemic target. So let us come to the case again. This patient who had an uncontrolled glycemic status, CKD stage 3, dyslipidemia, hypertension, BMI, and fatty liver. So usual medication, metformin, sitagliptin, rosuvastatin, and telmisartan, just an addition of a SGLT2 inhibitor, maybe dapagliflozin, can do miracle for this patient. These are the parameters that have been really shown to a lot of improvement after 3 months of therapy with dapagliflozin. Early intervention, it can prevent or delay different complications. What about the combinatorial approach in the diabetes management? All the guidelines have stated if the initial A1C is more than 75, combination therapy with 2 agents will be needed. And for those with an A1C or more than 9 or 1.5% above the goal, then 2 or 3 anti-hyperglycemic agents should be initiated concomitantly. This is also the AAC algorithm. All of you know that this picture is so bright and vibrant and informative as well. What about the different combinations with dapagliflozin? What about the DAPA and metformin combination? This definitely improves glycemic control. A1C reduction can be up to even 2%. It has a positive impact on systolic blood pressure, helps to control the blood pressure. It reduces HOMA, IR, and insulin resistance and CV events. And mostly, and most importantly, there is reduced incidence of hypoglycemia because mechanism-wise, these two drugs do not induce hypoglycemia. So these two drugs together combine and can do very good for the management of our patients. Now, what about this SGLT2 along with the DPP4 combination? Say, for example, sitagliptin. We know about this molecule sitagliptin. This is one of the earliest gliptins discovered, and it has its own CVOT trial published in 2015, the TECOS trial, that showed its non-inferiority as CV mortality or heart failure hospitalization is concerned. It has established itself as a safe CV safety agent. So what about if you combine your dapagliflozin with sitagliptin? Again, the duo can be dynamic. It reduces the better glycemic control is achieved. There is cardioprotection, DAPA plus CETA. There is enhanced renal protection. It improves the atherosclerotic cardiovascular risks, and it might help to decrease the genitourinary tract infection. So together, the duo can work dynamically because of its synergistic mode of action. They also have shown to reduce the glycemic variability. Compared with the control group, patient with DAPA group exhibited reduction in 24-hour mean blood glucose excursions. And the different studies can also be quoted regarding the glucose excursions in respect to sitagliptin. Well, this SGLT can also be combined with other gliptins as well. Say, for example, vildagliptin. My next speaker will be talking about vildagliptin, so I'm just skipping the much about vilda, though it does not have a so-called CV outcome trial, but a number of RCTs, number of field trials have proved it to be cardiac safe, and dapagliflozin can jolly well be combined with vildagliptin to give almost the similar efficacious result when combined with DAPA and CETA. So what about if we combine these 3 medications together, metformin with dapagliflozin along with sitagliptin? We can get a fixed dose combination of DAPA with CETA and metformin. Yes, the pills burden can be reduced. A patient with diabetes is usually forced to take so many number of medications because of all these complications. So combining these 3 essential drugs into one fixed dose combination can really reduce the pill burden while keeping all the beneficial effects intact. And obviously, 2 drugs how much beneficious, and three drugs, triple FTC definitely will show a betterment in the different parameters as far as reduction of A1C and other fasting BP, etc. are concerned. Three drug combination is obviously more efficacious. So we should conclude by stating that now our approach should be a more holistic metabolic care apart from a glucose-centric care. So there is a transition to a more holistic approach. And what multidisciplinary care that covers the cardio, renal, as well as metabolic profiles, which include obesity and fatty liver disease. And SGLT2 molecule has been proven to improve glycemic parameters for long, as well as its other comorbidities like heart failure, CKD, NFLD, established atherosclerotic cardiovascular disease, all points there is a notable benefit from the use of dapagliflozin and its community studies. So thank you for your patient hearing.